Welcome! We're diving straight into a high-stakes masterclass today, tackling one of the most challenging and lethal battles in infectious disease, endocarditis. Let's get right to it. Here's our game plan. We're going to start with a rapid-fire briefing, then hit a critical safety check. After that, we'll dive deep into the strategy, and we'll finish with a memory anchor to make sure this knowledge is locked in. Just a heads up, pay close attention to the shifts in pace. All right, listen up. Managing endocarditis is a war of attrition. You're not just fighting an infection, you are laying siege to a deeply fortified enemy. There's a reason we call it the long kill. This requires 4 to 6 weeks minimum of intravenous antibiotics. Why? Because the bacteria are hiding out in a fibrin platelet bunker. So what's your empiric therapy? You start vancomycin for MRSA and ceftriaxone for everything else. Now, if you're dealing with a prosthetic valve, you're going to add rifampin and gentamicin, but you have got to watch the kidneys. And look, once those cultures come back, you narrow the spectrum. The goal here is bactericidal, not bacteriostatic. Know the combo, respect the duration, and save the valve. That's your rapid briefing. Get it memorized. Now, let's go. Okay, hold everything. Before we go any further, we need to run our mandatory international medical disclaimer. This content is intended for educational purposes for international boards only. It is not medical advice. You must always consult official guidelines and a specialist physician for any and all clinical decisions. All right, Sarah, let's break this whole thing down. I want you to treat endocarditis like you're laying siege to a fortress. Your standard oral antibiotics, they simply won't breach the walls. So let's start there. Why? Why is the duration of treatment so incredibly specific? 4 to 6 weeks. What's so magical about that time frame? It all comes down to the vegetation, Dr. Collins. The bacteria aren't just free-floating. They're literally encased in this dense shield, a matrix of fibrin and platelets. The body's immune system, the white blood cells, they can't get in, so the antibiotics can only kill from the outside in. That's why we have to hit it with high-dose, intravenous, bactericidal therapy for over a month. We have to be positive every single organism is gone. If we stop early, that vegetation, it just grows right back. Precisely. Now, while we're waiting for those blood cultures, we have to start empiric therapy. So what's the standard board answer cocktail for a patient with a native heart valve?
Right. For native valves, the 2023 ESC guidelines point to vancomycin, gotta cover MRSA, plus ceftriaxone. That combination covers the giants. Staph aureus, viridin streptococci, and the Hayseck organisms. You know, that tricky, fastidious gram-negative group. But, Dr. Collins, I did notice that the new guidelines are really pulling back on using gentamicin. Why is that?
That's an excellent observation. And you're right, we are moving away from routine aminoglycosides because of the massive risk of nephrotoxicity. We really only keep gentamicin in the mix for very specific scenarios now, like enterococcal infections or prosthetic valves. And even then, we are monitoring those levels strictly. And for everyone watching, this is absolutely crucial. For specific dosing, you must consult the latest guidelines. We've put a link to the 2023 ESC charts right in the description for you. They are very, very specific about kidney protection, so please check them. So what about prosthetic valve endocarditis? That's a whole different ballgame, isn't it? It requires that triple threat cocktail?
Exactly. With a prosthetic valve, the landing pad is plastic or metal, and that allows for massive biofilms to form. So we use vancomycin and gentamicin, but we have to add rifampin. And rifampin is our secret weapon. It is the biofilm buster. It's unique in its ability to actually penetrate all that dense sludge that forms on an artificial valve.
Okay. Let's shift gears for just a moment here. It's time for our question of the day. I'm sure many of you have managed a patient on long-term home IV antibiotics, what we call OPAT. We want to hear from you. What were the biggest challenges you faced in keeping that patient compliant for 6 full weeks? Tell us all about it in the comments. All right, now it's time to make this information stick. Sarah, let's lock in the treatment rules. Long kill is IV. 4 to 6 is the key. Vancin Ceft for the native. Add rifampin for the prosthetic. Genta, watch the kidney. Links, review. Treatment locked. 4 to 6 weeks IV Vancin Ceft for native. Add rifampin for prosthetic. And you better believe I'll be reviewing those links.
Excellent. That covers our entire pharmaceutical assault.
But what happens when the drugs just aren't enough? What if the valve itself is literally falling apart? Well, you'll have to join us in our series finale, where we're going to cover the critical surgical indications for endocarditis. You won't want to miss it.